Hi everybody, I'm Ashley Rodriguez and I'll be doing my presentation on gender dysphoria. So before I talk about the diagnostic criteria, there are a few important things to note. The major one being that gender and sex are two completely different things. They seem to usually be used interchangeably, but it is important to explain the difference between the two. So a person's sex is defined as a person's biological indicators of male and female, like their sex chromosomes, sex hormones, and their non-ambiguous internal and external genitalia. Gender, on the other hand, is used to define a person's lived role as a boy or girl, or a man or woman. This is basically a way to be seen by the public and to be recognized legally. So here are some key terms in relation to gender dysphoria. So we will actually start off with gender dysphoria itself. Gender dysphoria is diagnostically defined as a person's cognitive discontent with their assigned gender. So someone who is biologically male, who has male genitalia, and also has gender dysphoria would not be happy living as a male. Some other important terms include gender assignment, gender atypical, gender reassignment, gender identity, transgender, and transsexual. The definitions are on the screen. I will not read them off just to save some time. So there are two groups of diagnostic criteria, one for gender dysphoria in children and another for gender dysphoria in adults and adolescents. So the criteria for gender dysphoria in children are as follows: a marked incongruence of one's expressed gender and gender assigned at birth for at least 6 months in duration, and it manifests itself in the following: a strong desire to be of the other gender or the insistence that one is of the other gender. This criterion here is one that must be met out of all of them for the child to be diagnosed. So in biological boys, there's a strong preference for cross-dressing or wearing female attire. So they may improvise by using towels or aprons or scarves to wear as long hair or for dresses. In biological females, there's a strong preference for only wearing the typical masculine attire. They prefer having short haircuts, and there's also a strong resistance to wearing female clothing. There's a strong preference in cross-gender roles in make-believe play. There's also a strong preference for the toys, games, and activities typically engaged in by the other gender. There are other criteria there that are on the screen to save time, and all of these are also associated with distress or impairment in social, school, or other important areas of functioning. So the criteria for gender dysphoria in adolescents and adults are as follows: a marked incongruence of one's expressed gender and their gender assigned at birth for at least 6 months in duration, and it manifests itself in at least 2 of the following. There's a marked incongruence of one's expressed gender and their primary and secondary sex characteristics. So in young adolescents, this would mean their anticipated secondary sex characteristics. There's a strong desire to be rid of one's primary and secondary sex characteristics because of the incongruence that they experience. So in young adolescents, this would mean the strong desire to prevent the development of secondary sex characteristics. There's also a strong desire for the primary and secondary sex characteristics of the other gender. There's a strong desire to be of the other gender. There's a strong desire to be treated as the other gender by others. And there's a strong conviction that one has the typical feelings and reactions of the other gender. These are also all associated with distress in social, occupational, or other important areas of functioning. So the prevalence of gender dysphoria in adult biological males range from 0.005% to 0.014%. And the prevalence in adult biological females, range from 0.002% to 0.003%. Not everybody with gender dysphoria seeks any sort of treatment, so these numbers are likely an understatement. So there are separate criteria sets for gender dysphoria, since expression of gender dysphoria vary with age. Criteria for children are defined in a more behavioral way than for adults and adolescents. Young children are less likely than adults and adolescents to express persistent anatomic dysphoria. So they may show signs of extreme distress, like crying, after a parent tells the child that they are not really part of the other gender and only desire to be. They may not also have the support systems available to live the role of their preferred gender, and they may feel distress when that is interfered with. In adolescents and adults, extreme distress is present because of the incongruence between their biological sex and their identified gender, but this distress can be decreased by the support systems available and the knowledge that there are treatments out there for them, like sex reassignment surgery. Impairment, like the development of depression, substance abuse, and anxiety, are all consequences of gender dysphoria. So the onset of cross-gender behaviors usually occur between ages 2 to 4, which corresponds to the developmental time period in which children usually begin expressing gendered behaviors and interests. Some preschool children express cross-gender behaviors and more rarely label themselves as the other gender. Some children also express anatomic dysphoria, where they are uncomfortable with their sexual anatomy and wish to have that of the other gender. This is usually more prevalent in children who are closer to approaching puberty. Rates of persistence of gender dysphoria from childhood into adolescence and adulthood for biological males range from 2.2% to 30%. This persistence for biological females range from 12% to 50%. So in adolescent and adult biological males, there are two trajectories for the development of gender dysphoria. The first is early onset gender dysphoria, where the gender dysphoria starts in childhood and continues into adolescence and adulthood. Sometimes there will be a period where the gender dysphoria stops for a short period of time and then starts up again. When the reoccurrence of this occurs, clinical consultation is usually pursued, usually for hormone treatment or sex reassignment surgery. The second trajectory is late onset gender dysphoria, where it begins around puberty and sometimes even much later than that. Some individuals with late onset gender dysphoria express that they have had desires to be the other gender, but they never told anybody about it. There are others who do not remember having these feelings during childhood. In adolescent and adult biological females, the most common trajectory is early onset gender dysphoria. So some risks and prognostic factors include temperamental factors, environmental factors, and genetic and physiological factors. The definitions are on the screen to save time. Cultural considerations. So gender dysphoria occurs across many countries and cultures around the world. It is not limited to one specific country or culture. So in 1923, Magnus Hirschfeld was the first person to distinguish homosexuality and what would eventually be called transsexualism. Physicians in Europe began experimenting with sex reassignment surgery in the 1920s already, but it only became popular when an American biological male named George Jorgensen went to Denmark as a male and left as a trans woman named Christine Jorgensen in 1952. For decades after that, many healthcare professionals expressed how critical they were of this procedure. A 1960 survey surveyed 400 different physicians who were in the majority of opposing gender reassignment surgery. They believed it to either be a severe neurotic or psychotic delusional condition that was in dire need of psychotherapy and reality testing. These thoughts are now no longer the case, and transition from one gender to another is supported in carefully evaluated individuals. The healthcare systems in only a few countries around the world now cover medical services needed for gender reassignment surgery. Today, many individuals with gender dysphoria prefer to be diagnosed with a medical condition rather than a mental disorder, since that's what gender dysphoria is considered right now. That way, there's less stigma towards them, and medical insurances will be more likely to cover their procedures. So, there was no mention of transsexualism in the ICD-6 or 7, but in the ICD-8, sexual deviations and personality disorders were separated from each other, and transvestitism was included for the first time under the sexual deviations umbrella. There were further amendments made to newer versions of the ICD, and presently there are proposals to recommend a name change to gender incongruence, and for the entire diagnostic category to be moved outside of the mental disorder section of the ICD. In the DSM-1 and 2, there were no diagnostic criteria for gender identity disorders. In the DSM-3, there were 2 diagnoses that appeared for the first time. So for children, there was a diagnosis of gender identity disorder of childhood. For adolescents and adults, there was a diagnosis of transsexualism. Again, there were further amendments made to newer versions of the DSM. Currently, in the DSM-5, the name is officially gender dysphoria. So one assessment instrument included the Gender Dysphoria Scale, or GD scale, which was an MMPI subscale. It consisted of 31 items, and the Gender Dysphoria Scale score was determined by the total number of items out of the possible 31 answered in the appropriate direction. This was used to determine the presence of gender dysphoria in only biological males by asking them questions about their lifestyle type, and they answered in true-false answers. This was developed in the 1980s, so there are problems with it, obviously. It brings out a lot of false positives, so it would not necessarily mean that males who underwent this had gender dysphoria. So in general, there are a lot of psychological assessments that were done for those with gender dysphoria. Assessments are done to determine an individual's general functioning, body image, as well as their intellectual and emotional coping mechanisms to determine psychopathology. In regards to the diagnostic procedures for children and adolescents, the inclusion of parents and caretakers is essential. Procedures in children are done to gauge the intensity of gender dysphoria. So information on different areas of functioning were gathered so that, if needed, psychological interventions could be made. A psychodiagnostic assessment is used more for adolescents than adults. Adolescents who have entered puberty could be given gonadotropin, releasing hormones to stop further puberty-related physical development from happening. The physical effects of this are reversible, so it gives adolescents time to really be sure that this is what they want to do. So some differential diagnoses include nonconformity to gender roles, transvestic disorder, body dysmorphic disorder, schizophrenia, and other psychotic disorders, and other clinical presentations. They're on the screen. Just to save time, I will not read them out. So treatments could include psychological as well as medical. So psychological treatments can help the individual figure out if they are confused about their gender identity, to help them find the course of action to take with their gender dysphoria, or to find ways to live their preferred gender part-time, of course in an accepting environment. Psychological treatments can also help in informing the individual about the benefits as well as the negative side effects to hormone treatments. There is also usually a period of time required for psychological treatment or clearance before anything intrusive occurs, like surgery. There are lifelong impacts of transition that the individual needs to be aware of before undergoing anything. So medical treatments include hormone treatment as well as surgery. Hormone treatment for females transitioning to male would take androgens to deepen the voice, to grow facial hair and body hair, and have a more masculine body shape. Hormone treatments for males transitioning to females include anti-androgen compounds like the 2 mentioned here to suppress male sex characteristics. Facial hair growth is resistant to these, so laser hair removal would be needed. Voice therapy can be used to help the individual use their voices differently. Estrogen can be taken to induce female sex characteristics and make their body more feminine. So surgery for males transitioning to females, they can undergo these procedures. Surgery for females transitioning to males is a bit more complicated, though there is a preferred method. This is the case presentation. I will not read it to save time. The information is in the handout that I have provided. and these are my references. Thanks for listening, everybody.